Welcome to Grand Rounds. It's really a special honor for me this morning to introduce our speaker, Dr. Lenny López. Dr. López is Associate Professor of Medicine and Chief of Hospital Medicine at the San Francisco VA, part of UCSF. Lenny received all his education from the university, most of his education from the University of Pennsylvania, and then moved on to Boston, where he did his residency. He did a fellowship in general medicine. He did a fellowship in health disparities, and during this path, got a master's in public health and a master's in divinity, which makes him, I think, extra special. He's been a clinician, a researcher, a funded scholar, and a mentor to many, many trainees and junior faculty. And I think I could talk for a long time, but I think I'll stop and say that New Brunswick puts forth amazing people in this world. And Lenny López was raised here in New Brunswick and went to school in New Brunswick. So welcome, Lenny.
Thank you. Thank you very much for those kind words. And I think the summary you gave just tells you that I love being a student. So let me share these slides. So my goal this morning is to do a little bit of a broad overview of where we are with Latino health and healthcare disparities, and to frame it around the new impetus and interest in precision medicine. We won't be able to cover everything, but hopefully we'll get to some questions in the Q&A and the chat at the end. But this is an exciting field of study. It's burgeoning, and I would encourage folks to jump in and read as much as you can. I have no conflicts of interest, which means that I'm poor. And I actually get to, this is my view from Land's End in San Francisco. So the San Francisco VA is on a beautiful parcel of land, and I get to do my famous walk meetings with all my mentees and colleagues. So this is an actual view. And as Dr. Sharma was saying, I was born in New Brunswick at St. Peter's University Hospital. I'm thrilled to see that it's part of Rutgers. And I spent my first 10 years of life and have fond memories of the park across the street from this hospital on Easton Avenue. Someday I'll get back to New Brunswick. And very briefly, this is the outline of the terrain we're going to cover. And I wanted to ground us a little bit in the history of Latinos and healthcare disparities, and to really highlight how recent the field is in terms of research and interventions. Discuss precision medicine with a focus on social determinants of health, and then focus on a few of the tools that we now know well, with plenty of evidence, scientific evidence of things that work in the reduction and elimination of disparities. And we'll wrap up with some examples of structural solutions to this problem. And I always like to talk about this, about North meets South, because really the Hispanic or Latino population, I'll use those terms interchangeably, is really a growing group in the United States, with 55 million Hispanics in the last census. And by 2060, 1 in 3 Americans will be of Hispanic origin. But only until recently have we really started gaining data on a national level for Hispanics and health. And I like this slide only because I just always want folks to really check their stereotypes of what Latinos look like at the door. Because it's every shape and color, flavor of the rainbow, color of the rainbow. So every ethnicity and race is part of this group. And that's because there's a complex geographic heterogeneity in Latin America. And depending how you define it, it's comprised of 20 countries. And if you include all of the countries, including the French and Dutch speaking, Portuguese speaking, it's 34 countries, all of them with their own histories, political, socioeconomic, cultural, and even language differences and trajectories. And that really impacts what happens with Latinos as they come to the United States, because the migration histories are complex. And there are scholars who specialize in these areas in terms of these patterns. You know, not all of them go to urban areas, and many are in rural areas of the country, and now more recently in areas where there weren't many Latinos in the past, as far all the way up into Canada as well. And really, the sending and receiving communities in the United States are all different. So Latinos in the Southwest have a very different experience than Latinos in New York City and New Jersey, and Latinos up in Maine and Latinos in Oregon. So the sending and receiving communities really impact these sort of heterogeneity that exists in the population. And really the history of looking at healthcare disparities, really the first national report was Margaret Heckler's report in 1985. It was commissioned in 1983 under the Ronald Reagan administration. And she was the Secretary of Health and Human Services and commissioned this 2-year report looking at what was then called Black and minority health. And it was a real significant contribution. It was 8 volumes of studies that were included in this study, in this report. And importantly, embedded in this report was the first, I would say, quasi-national study of Hispanics that was undertaken between 1982 and 1984. So only 40 years ago was the first national study. Prior to the study of the Hispanic Health and Nutrition Examination Survey, there were only small cohorts, epidemiologic cohorts that were primarily in the Southwest. And so they were not representative, and actually led to quite a bit of epidemiologic confusion, which we still sometimes today hear about the Hispanic or the Latino paradox. But this study that was done in the early part of the first half of the 1980s consisted of 16,000 participants, and the first one to have Latino subgroups. Prior to this, primarily the data we had were for Mexican and Mexican Americans. And at the time, this study was done with population survey sampling schemes and represented about 76% of the Hispanic population. And it was comprised of Mexicans from 5 southwestern states, Cubans from Dade County, Florida, and Puerto Ricans in the New York City metropolitan area. And it was from infancy to at older ages. But it was really the first one, and you can actually access this entire report. It's on the web in a typescript that clearly showed it was typed on a typewriter. So it's an interesting read in a lot of different areas. And really, from that point on, the next major landmark study in sort of that was national, commissioned by the Institutes of Medicine, now the National Academies of Science, was the 2003 landmark study titled Unequal Treatment. And this is another massive tome that compiled thousands of studies by disease, health service research, and epidemiology around the state of where at the turn of the millennium that we had in terms of disparities. And so this tends to be the grounding point. But for Latino studies, it's really the Hispanic pains back in 1982 and 1984. And shortly thereafter, AHRQ, the Agency for Healthcare Research and Quality, began to do annual healthcare quality and disparities reports. And the first report started in 2003. The most recent one is in 2019. And what's important about this is that it's freely available on the web. And it allows you to see both primarily outpatient, but there are inpatient quality metrics. And unfortunately, this one slide will be the summary of many of these volumes. But here, this one slide shows quality measures by race ethnicity compared to white as the reference group. And it looks at the years of 2013, 2015, 2016, 2017, and does a summary. The numbers in the colored bars represent the number of the quality measures. And the message is pretty striking that in 2017, essentially most of the quality measures had no change or were worse, and very few things were actually improving. So we have a lot of work to do with regards to these measures and the reduction of disparities. So harkening back to 1982 to 84, when the Hispanic Haines study came out, now we have what I like to call the Framingham study of Latinos. It's not based in Framingham, but it's of the same landmark magnitude. And it's a NIH-funded study, and the initial wave, it is currently in its third wave of data collection. Its initial wave was funded by most of all of the NIH institutes, includes everything from craniofacial, dental, all the way to cardiovascular disease. And it was a sample of a contemporary sample of 16,000 Latinos, 4,000 from 4 sites in order to allow for capturing the complexity of Latino subgroups. So the cities are San Diego, Chicago, the Bronx, and Miami. And the first studies that came out the first study that came out of the study was published in 2012 in JAMA. And it was the first picture after the 1980s on a national scale as to what was going on in the healthcare of Latinos. I'm only going to focus on cardiovascular disease, but there would be data for all health measures. And what we can see by looking at this table is that the mean age, this is not on the table, I'm saying this part, the mean age of the cohort in 2008 was 40 to 42. So this is a relatively young group of participants, yet they had very high levels of cardiovascular risk factors. And there was variation by country of origin. And you can see that, for example, for hypercholesterolemia, the highest rates were for Cubans, Mexicans, and Central American, and there are sex gender differences. You can see also for obesity, the highest rates were with Puerto Rican women, and then followed by Dominican women. And again, very high rates, prevalence of obesity in the 40 to 50% range of the cohort of 16,000 participants. Similarly with hypertension, very high rates, 20 to 30% across the board, across the groups, with the highest rates being amongst Puerto Ricans and Dominicans. And diabetes following similar patterns with obesity and other metabolic derangements, again, rates about 20% across, with the lowest rates being amongst South Americans, which by itself is a complicated category, considering that South America is very large and very heterogeneous, but it's the best granularity they're able to do. So with this kind of a picture, we see a looming cardiovascular tidal wave for Latinos in the US. And I like this cartoon primarily because you can say that it's half empty, definitely half empty, but just listen to you're always a pessimist. So I'm of a glass half full type and feel that we have hope and we have the ability to address this cardiovascular risk factor deluge that's coming. And I guess the one way to think about it is, where do we begin? Because this is a sort of a massive problem, a big challenge. And in 2015, President Obama at the State of the Union put on the map this new initiative that the NIH was going to lead on precision medicine. But what I liked about it is that people often forget that we get seduced by the idea of all the omics, metabolomics, genomics, proteomics, and it goes on and on. But from the actual speech, he defines it as an emerging approach for disease prevention and treatment that takes into account people's individual variations in genes, environment, and lifestyle. So all of it is part of precision medicine. And there was this great commentary piece. I'll read part of this quote, but it states genomics is only one approach to improving health, and for the most part cannot be used in isolation from other factors or determinants of health and disparities, including socioeconomic factors such as housing, education, and access to care, because the dialogue really in the field for a very long time had been really focused on healthcare as opposed to the overarching issue of health. So this was signaling a big shift in the discussion in the field. And what I posit is that sociocultural tailoring is really a form of precision medicine, really tailoring to an individual's social, economic, cultural context, and really providing the best level of care, both for health and healthcare. And so the field really now focuses a lot on what's called the social determinants of health. These are only examples, depending on which framework you look at, it can be as few as 20 and as large as over 50 different factors. But they're all the things that we know as human beings we all need in order to live and thrive in the world. And this includes everything from the usual things we think around income and social status, but also things like social support, the built environment, physical environments, education, healthy child development, now what's called a life course approach to health and healthcare disparities. So really a lot of factors. And importantly, I like this image only just to highlight that they're all integrated. They're all work together. They travel together, and they often cluster in both positive and negative ways. So they don't work in isolation of each other. This is a nice graphic that Sir Marmot, who is one of the leaders in the world in the study of health and healthcare disparities in the UK, compiled what we've known for the last about 20 years in terms of data around what percent of health and healthcare is impacted by the social determinants of health. And basically from these three pie charts, you can see 45 to 57% of health measures and healthcare measures are impacted by the social determinants of health. Only a small part of it is due to behavior, genetics, environment, etc. So they are a significant issue that needs to be addressed if we're going to make a dent on the disparities conundrum. And what best thing to do? Why not begin to collect social determinants of health? And there's so many. The IOM actually, the National Academies actually put out a statement and a study, consensus study of what to collect based on the data. So it was a consortium of experts in this area. And after, I believe it was 2 years of work, this came out in 2 phases, they proposed 25 questions which form the core domains and measures that should be collected when an individual enters the healthcare system. And then they actually prescribe frequency of collection of this data. And really it's 23 questions because some of the address and your census tract median income can be collected separate from the actual encounter. But it's all of the things you think of, including alcohol, depression, education, financial resource strain, intimate partner violence, physical activity, social connections, and stress. And these are all work based on validated scale-based questionnaires. And they've done simulation studies that were published and have shown that to collect this data takes less than 10 minutes. So collecting the social determinants is the building block of being able to address healthcare disparities. And as I mentioned earlier, the other term that's often used with these social determinants is intersectionality, because all of us are in the intersection of all of these factors that work together adversely or in a beneficial fashion. So this is really the direction that the discussion has moved in the last 15 to 20 years, that social determinants really are the key driver of health and healthcare disparities. And what I propose to do is just to talk about a few things in our armamentarium that we have to address disparities. But I always start with this I want to say it's Lenny López's dictum, and that's that all disparity solutions are local. There is no such thing as one size fits all. It's all going to work. We know this always works, because when you actually look at studies, they're all very contextual. And they're all highly dependent on a variety of factors that are unique to that particular setting. And today we don't have a lot of time, but I wanted to focus on a few that are particularly relevant in Latino health, and that is language and cultural tailoring. We'll talk a little bit about the data around patient navigation and health literacy. The chronic disease management model, which has been around since the mid-1980s, has lots of evidence. Community health models, and we won't be able to talk today about tailored mobile technologies, which are really now being merged together with patient navigation and community health models because of the ubiquity of internet access and smartphones. The apps are here to stay. So speaking about English proficiency in the Hispanic population, this is from the American Community Surveys, and it was tabulated by the Pew Research Center. And this is looking at the percent among those age 5 and older who are English proficient. And the key point here is that, as you would expect, foreign-born individuals have less proficiency, but overall, the group still has between 60, 70, 90% for those are US born, but then that is complicated by health literacy and health literacy issues. So although they may be proficient, their literacy or health literacy rates may be lower than an actual first blush interaction. So this still is a significant, language is still a significant barrier in health and healthcare. I wanted to highlight something because this comes up a lot, and this is a very recent study done by one of my colleagues here at UCSF, Alicia Fernandez and her group. And this is a repetition of a study they did earlier back in 2011 and another study in 2014, looking at the use of machine learning algorithms such as Google Translate in terms of accuracy in translation of sentences and potential clinical harm. And in 2017, Google Translate put out a new algorithm, which was much better than the original one. Prior to 2017, there were error rates of, depending on the language, anywhere from 40 to 60%. And now it's much better using this newer version of Google Translate. And this was a study that only looked at 2 languages, Spanish and Chinese. And they chose Chinese because the non-Western languages have much higher inaccuracies at baseline with machine learning algorithms. But they only looked at, specifically in this study, at emergency room discharge instructions. So this is a very narrow view of the complexities of using non-certified interpreters, whether remotely or in person. And what you can see is that the rate for Chinese is much higher, it's up to 20%. For inaccuracies in the translation. It's 8% or so for Spanish. But what's most interesting is that there is a significant percent when they looked at the inaccuracies for potential harm. And when you look at this under sentence content, the highest is around return precautions, which in the emergency room discharges is the most important, one of the most important things, where the rates are up to 23% for Chinese and 13% for Spanish. So a lot of complexity with this, and I don't think anyone would advocate using Google Translate if you were going to do something technical, such as legal work or healthcare work or anything. And the guidelines all say the use of certified interpreters is key. But I wanted to caveat it by the complexity of languages. Languages that are more unusual or more rare in a community are the ones that are where people are tempted to use Google Translate, and it could lead to potential harm. One other thing that I wanted to highlight about language was a study we did a few years ago when I was at Mass General in Boston, and we looked at specifically Coumadin, which is now being replaced by the DOACs or the NOACs or whatever abbreviation you want to use. But I wanted to pick something that had a lot of emphasis on communication. And for all of those of you who remember Coumadin, that required lots of adjustments and challenges and phone calls and follow-ups, and lots of things were going on. And most people were in an anticoagulation clinic. So we picked an anticoagulation clinic that had a high time and therapeutic range percentage. We wanted to let's go to the best place, get something that's very language intensive, and see if there are significant differences by language barriers. And there were, as unfortunately we found, that those with language barriers were less likely to spend high time in time and therapeutic range, and more time in the danger range of having complications, time and danger range. But what was most interesting about this study was that we found that those language limited English proficiency patients who use communication surrogates were worse off. And this really helped us understand and argue in the paper that's really important to understand whether people are using, whether the communication is really a dyad or a triad, how many people are involved in the care. It's not enough just to have the interpreter with the patient. A lot of these patients were older and probably were dependent on others to help them with their health care. And so translation needs to incorporate all of the providers that are involved in the healthcare of a patient. I want to switch gears a little bit to cover a little bit around community health workers. And these have gotten a lot more attention recently, but they've been around for quite a while, all the way back into the 1980s. They were being used in the Southwest around public health. And they have lots of different names. They're navigators, promotores or promotoras, they're peer educators. They come in lots of different flavors as well. They often most likely are they're lay people who are non-health trained, but some of them are highly trained. They can be sometimes peers, and sometimes they're also disease concordant. So someone who has hypertension and let's say diabetes works with someone else who also has hypertension and diabetes. So there's a lot of variation, and deciding which model to use is really dependent on the disease that you're trying to manage and the complexities of the context in which they're going to work. But importantly, they apply their unique understanding of the experience, the language, the culture of the population to do cultural mediation. They do language, they do resource engagement. And lots of studies have shown that they're really tightly correlated with patient activation. I mean, to be honest, I'm going to show you a study we did. I think most people need navigators when they're engaging their health and healthcare. And so there's tons and tons of data that community health workers are really key in eliminating disparities. And there are now states that have certification programs for community health workers, and sometimes are required if they're going to participate in trials or be hired by a healthcare system. So this is becoming more and more formalized over time. We did a study. This is one of my favorite studies. We had some funding to really try to improve colorectal screening, which is it's getting better now with some of the molecular testing that we have. But at this time period, colonoscopy was still the main form, and we were having in the Brigham Mass General Healthcare Primary Care Network, we had very low rates of colorectal cancer screening, especially amongst Latinos and especially amongst those with limited English proficiency. And so we had a grant to train patient navigators to take people literally, it was almost concierge service from their appointment time all the way to post-recovery and coordinating transportation, follow-up, which is another big chasm that needed to be crossed. People would have a colonoscopy and never follow up. So all of these kinds of challenges. And what I liked about this was that we were able to show quite dramatically, I think, that we increased, using the navigators, we increased the colorectal screening completion amongst the Latino patients, and they actually were, within the first year had crossed over and were having higher screening rates than non-Latinos. And similarly with those with English and non-English. So the non-English folks quickly overtook the rates for those with English, really showing that if you really engage patients, you can actually change these curves quite dramatically. And then we saw this, that we were able to compare with other sites. We only had funding for one site. Chelsea was the site that had the largest percentage of Latinos and limited English proficiency patients. And compared to other sites, this one clinic really went up above 70%. And actually the rates now, last time I was talking to someone, are in the 90% rate. So it's really been an impressive program. But another key feature of the study is that it took time. We started in 2005, started doing all the measures in 2006, and then it took us 5 years to really change the dial. So a lot of times we want quick, easy changes, but it does take time to make change. I wanted to have a moment to talk a little bit about chronic disease management, because this has been around for a long time, well researched, lots of evidence. And I just picked this one systematic review and meta-analysis to show that the key components that consistently were associated with the elimination of disparities, and this is around diabetes management, which has lots and lots of quality measures, is really the components of face-to-face. Now it'll probably be Zoom components. And the most important things were the intensity. All of these required more than 3 sessions. These were not one-time, sessions. They also found that the more closely spaced they were, the more patient activating they were. And all of them were multi-component. So everything from addressing literacy and numeracy to education to diet to physical activity. So these are complex interventions, but are part of our healthcare system. We just need more of it. And all the most successful ones as well involve community health workers, which is an important consideration when we think of the healthcare workforce. Not all of these chronic disease management skills need to be done by highly trained physicians. Linda Gallo from San Diego State University did a really nice systematic review of culturally tailored interventions in diabetes amongst Latinos. And these were the key things that were found to be successful in these reviews. They all addressed diet and literacy and education around cultural beliefs. Importantly, they involved structured community input. So these were not, the healthcare system coming in and telling people what to do. It was a bi-directional process of developing the tailored interventions. Those are the ones that were most successful. And one of the things that totally sounds non-sexy, but really makes a lot of sense, is teaching problem-solving skills. I mean, this is the stuff that doesn't sound like it's in the wheelhouse of a physician, but managing a chronic disease such as diabetes requires this. And this is where the patient navigators really do an amazing job. The other thing that was very interesting were booster calls and visits. This notion that you can do it very quickly with a short number of visits is clearly not going to be enough for a lot of these disease processes that involve multi-component lifestyle changes. And if you involve, just like the Coumadin study, if you involve families and friends in these interventions, the interventions were stickier. They were more likely to achieve their goals. And so I think that is another key, is that involving all the folks who live with the individual, part of the social network, the folks who facilitate health and healthcare for that individual are key to be involved in this. The other thing I was going to cover, which I think are really an interesting way of addressing sort of the concentration of these linguistic cultural services, are sort of creating what I call centers of excellence. We have them in many different things, but many times in large healthcare systems, patients are scattered across lots of different clinic settings, which may not have all of the resources for linguistic or cultural tailoring. And so creating an environment where everyone from the person doing the intake to the physician staff, the nursing staff, the team that are involved, being culturally concordant, linguistically concordant, makes a difference. I call it sort of the magnet school theory of arts or sciences. If you really want folks to excel in a particular area, get all of those needs met in one place. So that was the hypothesis behind this study. We did this using, again, the Brigham MGH healthcare system. And because of the way Boston is set up and the surrounding areas, it was easy to find the clinics where there would be a high proportion of Latinos and low proportion Latino clinics because of residential segregation in Boston. And our hypothesis was that for cardiovascular disease quality indices, there would be better, the Latinos would be better off in the high proportion clinics. And that is what we found. We found that those who were in a high proportion clinic were more likely to get cardiology consultation for their CAD and CHF, and also that their mean quality performance rate across quality indicators for CAD and CHF were higher for those who were in the high proportion clinic. We weren't able to prove a mechanism, but we did know that those clinics all had high levels of cultural linguistic concordance and programming. I think this is back to the patient navigators and all of the other ways that people become activated in their healthcare. So this might be a way to concentrate limited resources to create these centers of excellence that could address some of these challenging disparities. I use this it's a very dramatic picture of building, iron steel beam workers in New York City, but really to think about bigger structural changes outside of the healthcare system, sort of back into the land of social determinants of health, and that there are many novel ways to address these things. And I wanted to cover one study because I found it to be incredibly illustrative of some of the things that are potentially awaiting for larger scale interventions. And this was done by one of my colleagues, Ann Thorndike and Doug Levy out of MGH, where they became, I remember this actually, it was over a several year period, they became very interested in behavioral economics and the interventions around behavioral economics and what is called choice architecture. And we've seen they had done previous studies and other folks had done studies with labeling, red is bad, green is good, and they've done this in many different settings, but it hadn't really been done in low income, predominantly Latino concentrated areas. And they decided to apply for, Robert Wood Johnson was at one time and still is, but at one time was really focused on community-based interventions. And so they did a traffic light labeling system with some financial incentives that they would get at the end if they were primarily not buying sugar sweetened beverages. And this was done in 2014, and they had a 2-month ramp up period where all the labeling was set out in the store, and there was signage, and there were people who were coming in. There were study coordinators who were talking to people, passing out flyers that this whole labeling thing was happening at the supermarket in Chelsea. And they were able to track what they were buying because of the credit card type-based system for women, WIC, and other sorts of social programs. And so they were able to see what the purchases were. And it was a highly successful study, but what's interesting is the blue are the intervention group, who basically wound up buying less beverages, sugar sweetened beverages over the 5-month period of the intervention, and were motivated by not only the labeling, but also that they would get $25 each month if they had lower beverage consumption, sugar sweetened beverage consumption and purchase and consumption than their own baseline. And the control group, which didn't really get any education around this at the same supermarket, actually, the numbers actually went up. They were buying more sugar sweetened beverages. So these are the kinds of things that can be used to address social determinants, taking it outside of the healthcare system and getting people really to engage in their health and their lifestyle. In that same vein, for a very long time, the mantra in healthcare was that all of this stuff is really not our problem, and we're here to deal with disease. And public health over there somewhere, the Department of Public Health takes care of prevention, but that's not what we do. But that's really changed in the last 10 years with large health insurers and healthcare systems engaging and spending money and investing in solving the social determinants of health issues. For example, this here is from 2019 with United Healthcare funded a $12 million grant for a 65-unit housing center to address homelessness in Los Angeles, and really increasing these public-private partnerships are showing up all over. There's this one that was my favorite study, which was the University of Illinois. They noticed that many of their high utilizers of the emergency room were homeless individuals. And the housing is not just housing. There was social work and other services that were part of that. Especially they included addiction recovery services. By spending $1,000 a month per patient or participant in their housing unit, they were able to save the $3,000 per day that they were spending in the emergency room for the same individual. So I really love this example because the money really pans out for folks who are interested in the bottom line. This was another very creative one earlier last year with Anthem Blue Cross partnering with Project Open Hand, which was basically creating medically tailored meals for patients who had coronary artery disease, hypertension, CHF, and diabetes. And for all of those, I'm a hospitalist who are in the hospital. We see a lot of diet indiscretion causing hospitalization around CHF and diabetes. So this is another novel way of dealing with social determinants of health, and it's being paid for by insurers. And the last example I wanted to show was another one from last year, where Spectrum Health really, this is a commitment in West Michigan, Southwest and Southwest Michigan, investing $100 million, so $10 million over a 10-year period, specifically around housing and transportation and funding community-based participatory interventions in the community that's the catchment area of this healthcare system. So these are all examples of how we can address the social determinants outside of the walls of our healthcare system. So I really want to emphasize we've covered lots of different things, but really let us not leave Latino health to chance nor politics. I mean, we can do this in a well-researched, well thought through program that could really change and make an impact in Latino health and healthcare disparities. And one of my favorite slides of all time, many of you may have seen this, is Ebbinghaus's forgetting curve. I don't know if you've seen this before, but Ebbinghaus was a German psychologist, experimental psychologist, one of the first in the 1880s, was trying to sort out how much you retain over time if you don't have any reinforcement of your learning. This has been panned out in different studies, but essentially it dissipates pretty quickly. And so I hope that we can leave the conversation remembering that all disparity solutions are local. Language and cultural tailoring matters. Patient navigation is a powerful tool, especially combined with chronic disease management and community health models. And maybe another time I'll come and talk about mobile technologies, which is another area that I've been working in. This is just a review a little bit of what we discussed around social determinants of health, and that Latino health on a national level is only 40 years old in the land of research. And we have a lot to learn, but that structural solutions will be a key component to addressing this tidal wave of cardiovascular disease risk. So I'd like to leave you with my setting, but I'm happy to take questions for the next 10, 12 minutes or so. Now, I probably need to close out of this, right? So.
Thank you, Lenny, for a wonderful talk, and clearly a lot to learn and a lot to do in our communities. While we're closing your talk and opening up for questions, I'd urge our audience to kindly post the questions in the chat box, and Dr. Cohen is managing the chat box. I do think that focusing on communities and building is the right way to go. But the one thing I worry about is, in lots of parts of Europe, at least this has been seen, I'm not sure they do healthcare as well with navigation, but these communities then get segregated socially from the rest of society. And that sets up its own sort of problems. I've not seen it in the healthcare space, but just in integration. And what are your thoughts?
No, that is a great point. I think in this country we have a similar problem. I've done a few studies looking at what I was calling at the time minority serving hospitals. And actually it turns out, for example, for African Americans and Blacks, about 10% of the 4,200 large acute care hospitals in this country take care of almost 80% of the African Americans. And that's because we have residential segregation. So I think a lot of these things are challenging, as you're highlighting, Dr. Sharma, that really getting into the communities is going to be key, because these communities oftentimes wind up concentrating all of the negative health, social determinants of health because of a lack of resources. In the field now, people talk about resource-deprived settings, that historically these things exist because of housing laws, segregation laws, loss of jobs, loss of work, as in health insurance in this country is so tied to work. So there are lots of these factors that I really think that this engagement with the community is going to have to be part and parcel with the interventions. Otherwise, the patients will just keep arriving with all of these complex medical issues with no resources available in their own communities to deal with their health. I mean, that's a really great point. But these are legacies. I mean, these are things that are structural and have existed for a long time. And really the conversation has really changed in the last year and a half. I mean, really surprising. I remember when I started doing research in this area, which wasn't that long ago, back in 2005 and 6, we didn't talk about race because we were afraid to talk about race. We didn't want to scare anyone, alienate anyone, and we didn't want our research to be sidelined into, secondary, tertiary journals because we have the big R word in the title of our papers. And so the conversation nationally has changed tremendously.
Thank you.
Yeah.
Thank you, Dr. Lopez. It was a fantastic and insightful and obviously timely talk for many ways. You talked about social determinants of health, and you talked about you kind of touched a little bit on access to care, especially with interpreter services. And I'm wondering if you can talk a little bit about using what you talked about or any other information about either COVID-related outcomes. We know that the Hispanic community has higher infection rates and higher mortality rates, and also some evidence seemed to come out that relates to similar findings and decreased access to care for vaccinations. So I wonder if you can touch on that.
Yeah, I mean, I think again, the structural social determinants of health really have come to the forefront. All the folks who in the land of epidemiology and infectious diseases who study pandemics knew this was coming, because this is what happens in pandemics. The most vulnerable of society, those with housing challenges, those with, in this scenario, their work required them to be in contact with lots of different people, really are the ones who also are less likely to have healthcare access to high quality care, understanding, navigating a very complex healthcare system. I can't even imagine trying to do that and not speak the language. These are really incredibly big barriers that I think the pandemic highlighted. They've always been there. I remember when the pandemic started, there was a lot of conversation about, well, maybe there's something different about African Americans and Latinos biologically and all of this and that. And I remember thinking, it can't be. It has to be that they're in the line of fire for these infections. And that's basically what we have discovered, is that it was all the settings in which they live. Here in San Francisco, we have large amounts of wealth gaps. We have communities. It's a small city, 7 miles by 7 miles, and we have communities that are incredibly wealthy generationally. And then we have communities, for example, the Mission, which is well known as a large Latino population, that has a very high social deprivation index, the index that the CDC uses to sort of mark the confluence of all of these factors. And so this is all within a very small geographical area. You have tremendous amounts of differences. And that was the area that had the most COVID rates, were the areas of poverty and housing concentration, where people are living, whole families are living in 2-bedroom apartments. Very, very challenging situation. Again, the importance of addressing the structural social determinants of health. We're not going to make a lot of progress. It's all going to be around the edges once they already have the disease processes in full swing and they engage with the healthcare system. Back to the message of prevention.
Yeah, absolutely.
Yeah.
Speaking of which, there's a comment from Dr. Fisher. Thank you for this wonderful, stimulating, and critically important presentation. What has to happen in the US is an emphasis on the value of preventive measures so that we don't have to expend so much on catching up. How can we create this paradigm shift toward prevention and health maintenance for all of the population?
It's there's a whole discourse around this, but the simple answer is follow the money. And I think that the health economists will tell you that we've incentivized our entire system for decades around all of the non-preventive things that we do in the hospital setting with procedures. For example, let me give you an example. This issue that we have challenges still having certified interpreters available for patients in a consistent, high quality fashion is because of the way we pay for it. It's all bundled under a hospital, fee that's not individually paid for. So, the incentives are not aligned to make sure that people have access to these services in a consistent, high quality fashion. And this is similar for prevention, and the same I think these insurers are beginning to move in the direction of addressing these social determinants by large investments in their communities. Kaiser Permanente, which is really big here in Northern California, hundreds of millions of dollars are being invested in housing. That's like the biggest, California is ground zero for a housing crisis, and so this is where they're investing their money because they're all tied to health. So again, prevention is the way to go. Sir Marmot, who I mentioned earlier, he's been saying this for now 50 years, that prevention is the way to go. When they've had the disease process, we've waited too late.
And in terms of access, there's a question about telemedicine. So how will vulnerable populations be affected even more with telemedicine, especially if the patients are not fluent in English? And I guess, thinking about, access to care, vulnerable populations may not be able to spend money to drive or to park at the hospital, but they also may not have enough money to have a computer or Wi-Fi access.
That's right. Well, I absolutely, and I think that's been highlighted with the COVID pandemic and what happened with education and healthcare for lots of people. But I'm lucky enough to work in the VA system, and the VA system has been a national leader in telemedicine and telehealth. And so they started actually before COVID. You can actually put in for when the patients are hospitalized. We have a large rural, Northern California is very rural, except for San Francisco and Sacramento. And so many of these vets don't even have Wi-Fi access. So you can actually put a consult in the computer for an IT consult, and they are provided with a tablet and a hotspot. And someone comes, even in COVID time, with all their PPE, and shows them how to use it. And they actually can have their follow-up visits based with the tablet and the hotspot. So they're actually given equipment. So this is, again, investments, the system investing in the structural inequities. You're absolutely right. It's of no service to someone to say you have telehealth and you're not going to be able to do it. It doesn't make any sense. So the VA is leading the field in this, and I think we'll need to continue that in other healthcare systems as well.
Great. A question about approaches, whether different approaches should be taken for improving disparities in less common diseases, or can we apply the same model to common diseases and our less common diseases?
That's a good question, and I would say that the tools probably will work in less common, more rare diseases, and it might be that those are especially the ones that need to be in a concentrated fashion, a center of excellence kind of model, where you have chronic disease management and you have all the necessary support services. That would be my answer to that. I don't think we have lots of data in that area. I'm thinking of rheumatologic diseases because a colleague of mine is working a lot in this area, and it's all about very similar approaches that we're using, that we discussed today in this short talk.
Yeah, I'm sure.
Mm-hmm.
Well, maybe one more question before we wrap up.
Yeah.
There's a question about the conversation regarding limited number of healthcare workers for the ever expanding unlimited needs will stretch resources and negatively impact those who depend on social welfare programs. We actually had Quinn Capers, formerly of Ohio State, I forget where he is now, as our second Grand Round Speaker of the Year, who talked about the lack of diversity in medicine. So wondering if you can touch on this.
Yeah, it's a great point. A lot of people have talked about this, and I'm sure he brought this up. We do have, serious recruitment and retention training issues, but I think really important is to expand the universe of who can provide these services. Physicians are a very long-term, expensive approach to dealing with most of these things. The patient navigators, these chronic disease management models, they don't need physicians for most of these things. At most, it's a nurse. So lots of pharmacist-based interventions have been shown to be highly effective in medication adherence and medication titration, which is a major issue for like hypertension and diabetes. So we can really think even broader than just the physicians, but I think that will be key.
If I can ask a question, Lenny, in the inpatient setting where we have such brief relationships with patients and are trying to establish a connection, are you aware of programs that have navigators, maybe for the 4 largest communities we admit into our hospital, ethnic communities? If we got navigators that can help between the inpatient and outpatient, and then look at length of stay, readmission rate, I suspect this could have profound impact if we just picked a few communities.
Yeah, so this is a big area, and there's a lot of interest in exactly what you're talking about, and also having the hospitalist model. A lot of them are moving into the short-term follow-up between hospital discharge and the primary care visit as doing telephone visits. At the VA, we're beginning a program that uses telehealth to actually, use the tablets and connect with people because we had connected with them. And so this is exactly this is an area that's really, really fertile in terms of next steps, because it would certainly make a big difference, especially engaging. Patient activation and engagement is the key. Yeah.
We need the CEOs to buy in.
I know, the money. We need those hundreds of millions of dollars.
Right.
Absolutely. But it's exciting that the field is moving outside of the walls of the healthcare system. That's exciting.
Okay. Well, Dr. López, thank you so much for a wonderful talk. And I think you'll get an email from me pretty soon about when we can have you come back again in the near future.
Oh,
and
absolutely.
maybe even in person. So you won't have to wake up at 3 a.m.
I had a wonderful time, and thank you so much for inviting me, and for all of you to deal with Zoom fatigue as the first thing you do for the day. So thank you so much.
Thank you, Lenny. Thank you.
All right. Bye, everybody.
Bye. Thank you.